You're watching Parker Success Academy Clinical Rounds with Dr. William E. Morgan.
Hello, I'm Dr. William E. Morgan, and this is Clinical Rounds, where we explore topics that are clinically relevant to doctors in the field. Today I have a very special guest, Dr. Stu McGill. Stu, welcome to Clinical Rounds.
Thanks so much, Bill. I'm looking forward to this. It's been three years, I believe.
It has been. It's been a minute. But we've been friends for many years, and of course, you are one of the most significant spinal researchers in the world, very prolific, and someone I've followed for many years. And but not just a researcher, but someone who's very, very tied into the clinical applications of the research. So you've had quite a journey. Can you share with the audience a little bit about yourself and your journey?
Yeah, I'm just going to pick up on what you said there, Bill. We've been friends for many years, and the audience may be interested. I didn't start out this whole life with the thought I would ever be a clinician. And you'll remember years ago when you were in Washington, where I would call you. We hadn't even met yet, but you were always this savvy, sage voice, and I would call you about a clinical something or other, be it an issue or a patient, where I was just looking for that clinical wisdom. And I called on you many times, and I could also count on the wisdom I was seeking. So I just wanted to point out that friends for many years is absolutely correct. Now I've forgotten your question.
Well, tell us a little bit about your story. I like to add in there that I would call you, basically, when I was consulting at the White House, I had some issues that I consulted you on as well. So it's been a symbiotic relationship. But you've had quite a journey from being a scientist, researcher, to understanding and applying this to the clinical realm to make people's lives better. How did that journey transpire?
Yeah, it's a very strange story. I was a PhD student, and my supervisor was just beginning low back pain investigations for occupational and legal kinds of issues. And he said to me, would you write a program to measure backloads? And it was as simple as that. That's how it started. And he said, go to the anatomy lab and see the architecture of the things you need to model. And I did, and I was astounded that what I was seeing wasn't matching some of the very rudimentary models that already existed. So at that time, being a mechanistic guy and interested how things work, I just started with one question, Bill: how does the spine work? And things evolved from there. And I realized after a couple of years of probing injury mechanisms and pain pathways, etc., that I needed pillars of evidence, as I ended up calling them later. We made measures of living people with pain. So we would measure muscle activation profile, spine motion, measured stress distribution, that sort of thing. Then I realized I better start applying some of these loads that we suspect end up with causing specific tissue change and breakdown. So we did that with cadavers. Then I realized the radiologists were reporting features, and this was the topic of many of our early conversations. You were the guy writing the textbooks on interpreting MRI and matching the features to chronic exposures. So that became very important to me. And then I had to understand why certain jobs and certain sports creating specific exposures led to characteristic changes in the spines of those athletes, those police officers, those firefighters, etc. Then a few people would ask me very embarrassing questions. Why don't you put your money where your mouth is and do a clinical trial to see what you're suggesting really works? So that took us into that world. And I ended up starting the experimental research clinic at the university, where quite uniquely, we followed up with every patient we ever saw. So the assessment would allow us to subcategorize them into a, back pain is just a symptom. Well, what's the cause? Well, there's hundreds of causes. So we would subcategorize them and then follow up within 2 years to find out, did they even comply? Did they get better? Did they get worse? And that kind of thing. So we know exactly what our clinical success rates were for some of those subcategories. And I just kept evolving into this crazy thing that I am now. I retired, as you know, from the university 7 years ago, and I still see patients a couple of days a week. And these aren't ordinary back pain patients. These are the ones that are a bit stubborn. They aren't responding to the traditional care, shall we say. Anyway, that's it in a nutshell.
Well, I've been to your home, and it's up in the woods of Canada. So I think it's funny, the little town you live in, they have jets that arrive from Saudi Arabia and from around the world into this little town in the woods of Canada. And they're probably, what's going on here? And they're going into your neighborhood and basically being evaluated and
the guys at the airport, we don't even have border patrol here, but somehow Transport Canada knows from the manifest who's on the airplane. They're coming to see McGill, and I just drive right out on the tarmac, and they get into my car, and we come back here to the clinic.
Well, I think one thing that happened to you in your research that really, it's almost like the moment where, like Galileo, when he disproved something from Aristotle, that you looked, the anatomy books showed the grain of the interspinous ligaments going one particular way, and people had copied those for centuries going the wrong way, but you discovered the grain was the opposite. Is that true?
Yes, it was so interesting. I went to the cadaver lab my first time, examined the interspinous ligaments, which let me just unplug here, and I'm going to get a model. Can you still hear me, Bill?
Perfectly.
Okay, so the interspinous ligaments, which check forward motion, have an angle that run this way, so that as the spine flexes forward and those ligaments strain, they push the superior vertebra forward. Well, the anatomy books show them the opposite, that when you flex the spine, they pull the superior vertebra back, as does, say, the muscles of longissimus and iliocostalis. Well, I thought I had a mutant cadaver, so I went to the next cadaver, but of course it was exactly the same. And so all of a sudden, I started to realize how important posture was to shear load, and why certain people with laxity in a shear mode, if you were to test that, were often provoked by full flexion and engagement of those ligaments. Well, I traced that back to the 1800s in the English-speaking anatomical literature, and there it was. Now, interestingly enough, the German-speaking anatomical literature always had it correct. But Gray's Anatomy, Grant's Atlas, and then there was an anatomist in Ireland named Dave Halings, and he pointed this out, and he traced back to an anatomical artist in the 1800s. And now we know that every anatomical artist, including people like Frank Netter, the famous clinical series, only copied the previous artists. They didn't go back to the original anatomy, which I found so interesting. And over time, we found other anomalies like that. And with a little bit of lobbying, I happen to know one of the more recent co-editors of Gray's Anatomy, and they fixed the error. But anyway, it was a bit of fun.
Well, and also, I'm sure for somebody who's a PhD student and a researcher realizing, okay, if this is wrong, what can we trust? So it probably lit a fire in a skeptical mind or an inquisitive mind to look deeper and not take things at face value just because somebody else had said that, but to pave your own way. Because some of the things that you talk about go into the face of what is generally believed. Nonspecific lower back pain, which most studies are this nebulous exploration into something that I don't think you even believe it exists, nonspecific low back pain. What is that?
Well, I don't believe it exists, and that may upset a few people, but have you heard of nonspecific leg pain? Worse yet, let's say I have nonspecific leg pain. Could you give me an exercise for my nonspecific leg pain? So you see, it's a ridiculous argument. But it only shows me that the patient hasn't had a thorough investigation. So for us, again, I realized this 35 years ago approximately, we had to put substantial effort into designing a investigation of the person to understand why they have back pain. So we developed a quite a lengthy interview process where we could enhance what we called, as from an engineering point of view, the signal to noise ratio. What can we pull out of that that's gold from the patient? Why have they failed to have clinical success with other approaches? What were the roadblocks? Then we would do pattern recognition, realizing that certain types of pain pathways have a very characteristic set of features. Then we do provocative testing, first of all, of motions, postures, loads, activities, and then we work to specifically irritate individual structures in different modes. Then we add on some neurodynamics, etc. Can I give a specific example of a patient that would really
Certainly.
exemplify this, Bill?
Yes.
A couple of weeks ago, and I don't see the average back pain person. I only see the failed, more challenging cases. This woman came to me with the story, no one can find out what's wrong with me. I have nonspecific back pain, and I really get it when I'm driving to the point it's impossible for me to drive. Now I can sit down, but I can't drive a car, and people think I'm crazy. It's in my head. I don't think I'm crazy. And she was in this deep cognitive dissonant state. Anyway, so we started off, I listened to her story of all of this, and I was developing some hypotheses. And to us, the assessment is really a formulation and then a testing of the various hypotheses. And then, I would do the traditional clinical tests like the slump test and whatnot. Didn't create her pain. But as soon as I extended her knee and dorsiflexed her foot as if she was driving, there was the symptom. I would lift her head up and it made it worse. Not the slump, but the opposite. It made it worse. So if we get into an understanding of neurodynamics, extending the knee causes the sciatic nerve to migrate. And I should also say that it was the great toe on the right-hand side that would create a raging fire. So we have a pretty good idea that this is the fifth lumbar root that we're talking about. But what was it? She had 0 disc bulges. I looked for delamination of collagen in her disc. There was no bulge, no real flattening of the disc. There was no loss of turgor, no instability. But then I had a suspicion. As soon as she lifted up her head, I knew the neural track was traveling caudally. Something is hooking it up. What was that? So now, with that background, I said, I have to see your MRI. And I know who I'm talking to, the guy who wrote the clinical MRI of the spine. So you're going to love this, Bill. I knew I was looking for something that was going to hang up the right-hand side L5 root, but it wasn't the disc. Sure enough, there was a nasty little Tarloff cyst sitting right there on the, just past the exiting foramen. And I did a little bit of flossing. It made, now all of a sudden, the symptoms made sense. So we identified with precision exactly why she was failing, what the mechanism was, and do you know the psychological relief? You mean I'm not crazy? Oh, good, I've got a Tarloff cyst. But it's there's actually a fellow in Texas where we send our Tarloff cyst patients to, and it's no one has 100% success rate with those, but at least he has somewhat success. But anyway, there you go. It took us right down this rabbit hole. We didn't give up, and we looked at the MRI after we already had a pretty good suspicion of what we were looking for, rather than the opposite of putting the pictures up and saying, oh, there are a bunch of features.
Brilliant. Well, if we start going through that, my list was, is it a conjoined nerve root? Is it a tethered cord? Is it, is it a adhesive arachnoiditis? The things that would tether that and cause that pulling. And then you went ahead and did some neural flossing to free it up. And the studies on Tarlov cyst, to get specific, Tarlov cyst, for those who are not familiar, basically the sleeve over the nerve dilates and fills with cerebral spinal fluid, becomes large. Usually at S1, it's about 5% of the population have these things. And the studies on them, or the conventional wisdom is that they're benign, they don't cause any problems. Well, the reality is the response to treatment is so abysmal, they don't want to take responsibility for it because, if they go in there, cut it, or they put fibrin in there, it can cause aseptic meningitis and all sorts of things. So, yeah, the Tarlov cysts are unique in that the surgeons don't like touching them because every time they do something with them, unless there's somebody like your doctor who really specializes in them and understands them, the outcomes are not good. But that's perfect. So that goes in the next thing I'd like to talk about is you see studies that show that if you do an X-ray or an MRI early in the care, it confounds the outcome. They have a worse outcome. And if you show them the images, it's worse still. So the conventional wisdom is somehow taking those films early on leads to them thinking that they're frail. I would contend that it's the context that you and I put that in. Like you would look at that and say, oh, here's the thing, you've got a Tarlov cyst, it's a benign cyst, here's what we can do to get you better. If you conceptualize it and give them context, I don't think the patient will catastrophize that as much. But you're the researcher, you're the expert in this. What do you think about that?
Well, my opinion is first part is exactly what you said. It's the way you talk to people. So there was a study that came out a few months ago. What do patients really seek from their clinician? And very high on the list was, I want an explanation of the cause of my pain. And it's interesting, Bill, and we've had this conversation in the past where you'll give them as best you can a thorough, detailed explanation, and that patient will say to you, Doc, thank you for not treating me like a 5-year-old. They're so appreciative. And now they have a roadmap to follow. Here are some suggestions, and it might be for winding down the pain sensitivity or stimulating some kind of adaptation process. Here's some thoughts on the dosage and what to look out for, etc. So that's the first part of it. But now I'm going to take an opposite view because, as you know, in our world, our clinical subgroups form an N=1. Every single person is an individual.
I love it.
Do you know, last winter on my doorstep, and you know where I live. I live in a icy 6 months of the year. We have ice. Our lakes are hard. I had 2 people who slipped on ice and they felt something really give. Now, unfortunately, one went to an old-time chiropractor and he manipulated her from a slip and fall on ice. She came to me in a wheelchair and I said, has any imaging been done? So in that particular case, with a high impact trauma like that, yes, I would have radiology done immediately. So do you see, there's the opposite side of the coin. Interestingly enough, she'd fractured her sacrum and then had a manipulation. So this wasn't good. And it was a very similar style of story for the next patient who had a slip and fall as well. So in those kinds of cases, N=1, I think that's prudent to, so what I think the literature and many clinical discussions are really about, here's someone who comes in with back pain. It is of a character that you're really not suspecting fracture, malignancy, or something like that. And if the person says, well, I get it when I sit at the computer for 9 hours a day and I go for a walk, it takes it away. You probably don't need imaging at that stage.
True. So the other side of that, so you're an expert in spinal care. People who are experts put that in perspective. Unfortunately, most of the imagery is not requested by experts in the spine. Internal medicine docs, if nurse practitioners will order MRIs and X-rays, they have a report. if I read that report without any context as a spine expert, in-plate changes, motor changes, spurs, degenerative disc disease, facet arthritis. They read this, people it'll catastrophize them. Where I could look at that and say, my back looks worse than that. And to put it in context, this is normal age-related changes. We can get you pain-free with this treatment. When you don't have the expertise to put that scary report into context, the patient's left with a roadmap for living the rest of their life walking on eggshells. So that's one of the things I perceive. What do you think about that? It's the people who are least trained in the spine are the ones who request the most imagery for the spine.
Well, as you know, I very rarely want to see the report. I find for the type of patient I see, they're almost of zero use. A term like degenerative disc disease, and the poor patient, I agree with you, oh doc, I've got a degenerative disease, and that creates an image in their mind of they're only going to get worse. And I say, well, look at me, I've got degenerative hair disease and degenerative face disease. I've got wrinkles and white hair. And I said, but truth be known, it's not a disease. In fact, this will stiffen up. Now, humor me, how many older people do you know with disc bulges and that sort of pain? And they'll think about it and they'll say, yeah, well, my mother had pain in her 40s, but now she's 75, she doesn't have it. And I said, yes, it's stiffened out. And the turgor has returned to that joint that had lost its turgor as it lost a little bit of height. And now the micro movements that used to trigger pain have gone away. So that degeneration was a good thing. And I suspect you will be in that category too. Let's do a few tests. And it turns out, yes, when we probe them in a sagittal plane shear, a frontal plane shear, and that triggers their pain. And then I'll say, yes, but if you do this, what happened to your pain? They just said, oh, doc, it was gone. I said, bingo, they are empowered. You've now shown them a way immediately to mitigate that shearing micro movement. And I'll say, in 10 years, you won't be dealing with this, but here's a way to manage it in the meantime. Yeah. So you don't have degenerative disc disease. I don't have degenerative hair disease. So yes, it's very damaging, those kinds of MRI reports. But again, when you show the person, and you may notice behind me, probably 30 or 40 models of very specific back pain pathways, and how helpful it is on these models to show, here's what your spine is now, here's what the pain trigger is, here's what you're going to look like in 10 years, but your pain will be gone. Yeah. And now you've tied up the story for them and they go away.
You give them a happy ending. There's a hope for the future. And those are coming from our dear friend Jerome Fryer, also from the great frozen north with dynamic disc designs. I have a large collection myself.
He is such a gift. He's a chiro, as you know, in Victoria, BC, or just north of that, Nanaimo, which is where my daughter lives. And by the way, it's in the tropics as far as Canada goes, Bill.
The tropical part of Canada.
That's a tropical part of Canada, absolutely. But anyway, no, he's such a gift, and he has done such an outstanding service to the community in capturing the pain pathways that we and others have documented and putting them into these visual models so that the clinician can now explain to the patient, and it just empowers them to no end. It's
part of the whole package to empower them. I agree with that. Thank you so much for joining us today at Clinical Rounds, and you've been listening to Stu McGill, PhD, and researcher extraordinaire.
Thanks for watching another episode of Parker Success Academy Clinical Rounds with Dr. William E. Morgan.